Hello and welcome to the World Extreme Medicine Podcast. I'm your host, Stephen P. Wood. I'm an emergency medicine and critical care nurse practitioner, paramedic, and podcast host here at World Extreme Medicine. It's great to have you joining us today. We know there are a lot of podcasts out there and a lot you could be doing with your time. We're thrilled that you're spending your time with us for today's podcast. I am excited today to have a longtime friend and colleague, Dr. Vidar Magnusson. And Dr. Vidar Magnusson is joining us from Reykjavik, Iceland. And he's an anesthesiologist by trade and an intensivist by trade and a pre-hospital medicine provider, I think, for fun. But actually he holds a very esteemed position. He's both a consultant in anesthesiology and critical care in Reykjavik, Iceland, but also the national medical director for pre-hospital care in all of Iceland, which is an all-encompassing position. As he will tell you, it involves everything from directing their, what we call our 911, but I believe is your 112 system in Iceland, overview of training of pre-hospital care, as well as boots on the ground, clinical care, including helicopter EMS, which is going to be our topic for the day. So welcome, Dr. Magnusson, or if I may, Vidar, to our podcast today. Is there anything I missed there? Anything you'd like to add?
No, I think you covered it.
All right, great.
It sounds like I'm quite busy.
It does sound like you're quite busy, and I know that myself from having been in communication with you for many years and tapping into as a resource. You're a busy guy. And an important person there in Iceland who's really been an important piece of the success of pre-hospital medicine in Iceland. So we thank you for that.
Well, thank you. I think important sometimes also just comes from being one of few, and I think you need people to run systems. Systems don't run without people, and if there aren't enough of us people running the system, I think the few that are become critical for the functioning of the system, right? Right,
I would agree. And we actually have a little bit of a cosmic connection. You actually spent some time here in Massachusetts, and in fact, in the community where I had spent the last 10 years of my career doing emergency medicine. It's a very small town in Massachusetts, so that's a little bit of an interesting connection. You were a host for us or a speaker for us many years ago, I think at what was the second World Extreme Medicine Conference that was held here in Boston at the esteemed Harvard Medical School. And I remember you talked about ketamine, which now is one of my favorite drugs, not recreationally, but professionally. And we both also now come from areas that hold hot dogs in high esteem. Here in Boston, for whatever reason, we hold the Fenway Frank, which is a hot dog sold at Fenway Park, the home of our Boston Red Sox. And I think I waited 2 hours in line one early morning at the bequest of some Icelandic nurses to get a hot dog there in Iceland.
Yeah. We call them the town's best, or that's the name of the little boutique selling them, and they, as I say, they are they're held in very high regard. This is probably Iceland's most popular restaurant. It's just a small hot dog stand, and the way with all of the queues coming into there, and with the low overhead for that restaurant, they must be making money.
I imagine so, and I can confirm that it was a hot dog, and I enjoyed it, but I also found some. I loved the food in Iceland, especially the seafood there, and it was a great place to visit when I got that opportunity. But we're not here to talk about hot dogs today. We're here to talk about helicopter EMS, and we both actually have extensive experience in that. In a prior life, I spent 10 years as a flight paramedic at Boston Med Flight here in New England. You've worked in a number of different systems, both in the UK, the London HEMS program. You've worked in the Norwegian program, and you're now working in Iceland. And what we want to talk about today is really kind of, helicopter EMS and some of the differences in those systems, not to, simply compare and contrast, because I think, anyone could sit down and do that, but to really look at, a systems-based approach and kind of lessons learned from the different ways helicopter EMS systems are set up throughout the world. Your experience, obviously, quite vast. So we'll kind of, I'm going to leave it to you to kind of take it from here, and I'll chime in when I have a question for you. But I think this is a really interesting topic, and I think one that is really going to be insightful to our listeners. So, Vidar, I'll let you take it from there, and I'll chime in when I have a question.
All good. So, just to give you a little bit of a background, give the listeners a little bit of a background. My medical training comes from Iceland. I'm trained. So my basic medical training comes from Iceland, but Iceland doesn't really have a good system of advanced level training. So most of those who specialize in any specialist degrees in medicine will need to go abroad. Now we go. A lot of us go to Scandinavia, Sweden, Norway, Denmark. Many go to the US, UK, and then other European countries such as Holland and even down under. So we have some people in training in Australia and New Zealand. As I say, I decided to do my anesthesiology training in Norway, and one of the big reasons for going there is that Norway has a very strong pre-hospital system. They have one of the most and best renowned helicopter emergency medical systems in the world, and that was definitely one of the main reasons for choosing to go to Norway. What I didn't know at the time when I chose to go there is that it's to get into that system on a trainee level is notoriously difficult, because they don't really take in trainees. They base their system on consultant level anesthesiologists, but as I say, before I went to Norway, I had both a certain insight into pre-hospital care and an interest in pre-hospital care. I had been working on a ground-based ALS ambulance in Reykjavik, Iceland, for a few years. And then I had also worked on the Coast Guard's helicopter here for a couple of years before doing my specialist training. And I really enjoyed that, and that sort of was a little bit of the reason for choosing the specialty that I chose. I was trying to decide between emergency medicine and anesthesiology, and really couldn't decide between the two. So my decision was really to do both. Started off doing anesthesiology in Norway, and then never ended up finishing my emergency medicine. But that's sort of besides the point. I always had a focus on, when I was doing my training, I heard about this position. I read about this position in London, the London Helicopter Emergency Medical Service, London HEMS. And it was it was an article that came out around 2002 or 3 in BMJ, British Medical Journal Careers section. And it was an article that just sort of sparked an interest with me, because when I read through it, the article was interesting. It said sort of what the job was like, and it said something about the day starts by, you go through your equipment and you draw up 2 sets of anesthetic drugs. And I just sort of stopped there. You draw 2 sets of anesthetic drugs. So I knew how my days had started in Reykjavik. We went through our medical, drugs bag, and we made sure that we had our anesthetic drugs. We never drew them up. Right. And if you draw 1 set of anesthetic drugs, you're sort of hoping that something's going to happen. If you draw up 2 sets, you know something's going to happen.
Yeah.
And that was sort of my reason. I thought, well, wow, they're really doing something, and they are. I mean, they definitely have. This is one helicopter emergency medical system that provides trauma competence for one of the largest cities in the world. I mean, London has a population which is somewhere between 7 and 10 million during the daytime. With all of the migrant workers coming in from the counties around London, it's probably closer to 14 or 15 million, with everyone, tourists and everything over the day. And you've got one sort of trauma team with a doctor and flight medic that are ready to service the population in case of major trauma. And on top of that, they have a paramedic. One of their HEMS paramedics based on the in the 999 Central, the emergency medical dispatch, basically looking for and picking up jobs that are worthwhile for the service, where their special skills are going to be needed. And that's more than just sort of your normal priority one calls. I mean, they're specifically looking for jobs with major with high likelihood of major trauma. So, I mean, they're not trying to pick up calls such as just hit by car or something like that. I mean, it's much more specifically something like trapped under a car or trapped under a train, or, and they're looking for the ones with major impact and difficulty in breathing or unconsciousness, on top of sort of these serious mechanisms. And if you look at that, I mean, they are doing both procedures and delivering care that are state of the art in the street. I mean, they have been their approach to the rapid sequence induction in a pre-hospital setting has sort of it's been defining in a way. I mean, it's something that other systems tend to compare themselves to. I mean, not to say that their approach is the best. It's just one of the most publicized and one of the ones that is people will compare themselves to, both with respect to their rate of RSIs, with respect to their rate of successful intubations, what drugs they're using, et cetera, et cetera, et cetera.
Yeah, and so I have kind of two thoughts, and my hope is you can address this. One is I was very impressed. We were lucky enough to have some London HEMS faculty join us at that World Extreme Medicine Conference back in Boston. And I believe it was 2013. And I remember that for many reasons, but also our Red Sox won the World Series at that time. So that was memorable. but they kept referring to their kit, and I had no idea what they were talking about. I now know what that refers to, but it was their gear. Yeah, it was very impressive. Just their approach, their protocolized, kind of model, and their professionalism. So in the London HEMS program, are they staffing primarily emergency medicine physicians? Are they anesthesiologists? What's the makeup of a crew on the London HEMS helicopter?
So when I was there, looking retrospectively, you had about 60% emergency medicine, 30% anesthesia, and 10% something else. Most of those something else were surgeons. But people were coming in with various skill sets, and they're actually very smart in the way they recruit and have done through the years, because what they've done is they've both taken people from different specialties to try to bring into their system new knowledge and new ideas that they can then incorporate into the system through what you were talking about, their SOPs and so forth. So if they bring in, for example, a neurosurgeon who can show that pre-hospital craniotomies are a good thing, then that's something that they can develop. But
sure,
we're not there yet. But
right, hopefully not. Yeah, I mean, so that's in contrast. So in the United States, and I suspect we'll talk. We're going to talk about some of your other systems. In the United States, it's pretty uncommon for physicians to be operating in helicopter EMS. Yeah. Our system is mostly paramedics and nurses. There are some systems that use respiratory therapists, but it's not so common in EMS in general to have physicians, on ambulances, which I know in Europe and other countries is fairly common, or especially in the helicopter EMS system. Most of the time, these are very experienced paramedics, very experienced nurses who then undergo a lot of additional training. But it's pretty uncommon for it to be staffed by physicians. And then, and the system works well. But I think, it's good to hear about these other systems because I think, whether or not the United States chooses to integrate, physicians into helicopter EMS or not, I think there's a lot of lessons to be learned about the approach, and that, you're using not just emergency medicine specialties, but the anesthesiologists, surgeons, neurosurgeons, maybe even OBGYN, if there seems to be a role. I think we have a lot to be learned there. The other thing you mentioned that was of interest is, that they have someone sitting in the dispatch center, kind of culling out those calls. Here in the US, usually it's the decision of the ground units to decide whether or not they require transfer to a tertiary care center. And it's less likely that transfers are happening within large cities. So for instance, even in our largest city, New York City, I don't even think they have helicopter EMS programs that operate within the city. We certainly don't, generally respond to Boston proper. We're mostly doing, and I think this is true of a lot of helicopter EMS systems in the US, very rural response. How does that differ from the London HEMS program? It sounds like they do respond within London proper, and they do, kind of make some decisions about the calls they're going to attend on their own.
Yeah. So what we're talking about, I mean, we actually, in the London HEMS system, do respond to crew requests as well. I mean, that's a large part of the calls that they go to is when an ambulance crew has arrived on scene, sees that the patient has a need for a HEMS level intervention or support, and calls for that team. But as I say, on top of that, we have this both an automatic dispatch built into the dispatch system. So there are a few types of calls that will immediately call for a HEMS system, and then we have the HEMS paramedic on the desk looking for the specific jobs where the HEMS service might be of value. Back to your question, though. Sorry, what was the question?
Yeah. That happens from time to time in these podcasts, right? Yeah. So I think I suppose the question was, we're just kind of comparing and contrasting these programs. But so the question really you just answered, which was, do ground services have that decision-making capability, or is it?
You were talking about the city proper. I'll go back to that. So that being said, London has both. There are rural areas or sort of suburban areas around London that the helicopter services as well. So we're not just going to the inner city as such, and least of all because the helicopter doesn't really function as well in that setting as it does in the more rural areas that you're talking about. That being said, though, the traffic in London can be absolutely terrible, and because of that. Getting an advanced team out to the patient is often more of an issue than getting a patient into hospital. There are several trauma centres in and around London, but to get that specialised service onto scene and be able to treat a critical patient on scene before transport to hospital, that's sort of what the helicopter is for. So sometimes, and very often actually, the crew will just get dropped off by helicopter, but will travel into the trauma center by ambulance. But this is London HEMS. Then I've also worked with the Kent, Surrey, Sussex HEMS, which is, in the south of England. They cover a fairly vast region there, and that's much more closer to the rural areas that you're talking about, where you have larger distances, and the distance to the trauma center is such an issue that you will, actually need the helicopter for, lower acuity calls, although they're not actually that much lower, because I did a bit of sort of comparing when I was working for those two services, and the percentage of pre-hospital anesthetics is about the same. Maybe slightly lower in the rural area, but it isn't hugely different. What is different is, however, the number of stabbings, which are astounding in London, quite a bit less in the outside.
Well, that's an interesting topic we could maybe cover in and of itself one day. That I did not know that.
London is probably the knife crime capital of the world.
Really? Interesting.
Yeah, so they get a lot. They don't
advertise that very frequently. I mean,
no,
you would think that would be a draw. Yeah.
And the thing is, and that's one of the reasons why one of the signature procedures that the London HEMS had developed was the pre-hospital thoracotomy. Because they do a lot of stabbing-related trauma arrests, and they actually have a fairly good survival rate after pre-hospital stabbings. When they go into cardiac arrest, they do thoracotomies, and the survival rate when it was published last was around 17%, which is
pretty good. Yeah,
pretty impressive. Yeah,
I think that's a good. I mean, I think the United States focus is less on bringing that expert to that scene, and it's more kind of trauma referral to our tertiary care centers. So that's an interesting contrast. London, I think, aside just from their sexy orange suits, I mean, they're the cool, right? They always have the coolest photos of all the HEMS people as well. But aside from just, they're kind of that penultimate program, I think, that many HEMS programs look up to and kind of, think of as that, exemplar of how to do HEMS. Let's kind of, you also have done some time in the Norwegian system. Well, how would you compare and contrast those programs? What were the kind of differences that you saw between the London program and maybe what you did there in Norway?
So I think what's really good is that you're using the word program, because I think that's what we can say about the UK HEMS. There's a program, there's a system. They have a very strong culture for training. They have a strong culture for audit and clinical governance, for quality control. And I think all of these things are very rigidly controlled, and their medical directors and clinical leads are very active in sort of in just making sure that their protocols are in place, that they have. Yeah. So I like the word that I like the fact that you use the word program for the London HEMS system, because they have more than a system. They do have a program. There is a training program in that they take in staff that are at a more junior level than, for example, the Norwegian system, and they train them up. That being said, they have such there are so many people applying for positions in the London HEMS system that they are taking ever more experienced people, and there are very few people, I think, that are getting into that system now without having actually finished their specialist training. So they're usually taking in junior specialists now, where they used to take in residents and registrars. But the difference there we can contrast to the Norwegian system, where they have specialists. I mean, you come in as a specialist, you have your training, and they don't hold your hand as much through the first weeks and months of your pre-hospital career. So in the UK, there's a huge emphasis on training, on clinical governance, on quality and audit within the system. And that's, I think, partially because if you have lower level and less experienced people coming through, you're going to need a system to make sure that they are up to scratch before you send them out on their own. Versus in the Norwegian system, they tend to take in people into the system only once they have not only completed their specialist training, but actually usually have shown a critical care skill set that is, that lends itself to the pre-hospital environment. People that are able to work independently and sort of work without necessarily requiring the SOPs and the system that someone less experienced would need. Having said that, and having worked in both worlds, I actually am very thankful for having had that sort of training, for having learned pre-hospital care with a systems-based approach before coming into the less rigid, but definitely no less demanding system in Norway.
Oh, sure. And, it seems to make sense. The more, you have more experienced providers, they're less likely to want to actually probably engage in maybe the kind of training that a less experienced person might, want to engage in. Aside from the medical piece, this is an important part, or this was a very important part of the program I worked in Boston. And it really stemmed from just the number of programs that sprouted here in the 1990s. HEMS, went from just a small number of programs to just hundreds of programs as tertiary care centers realized that these are really referral programs, right? For one, that they're bringing patients in, and that those patients are usually critically ill, critical traumas, and that there's a revenue stream to some degree. And in the 90s, that led to also competition among programs, and so we ended up having a fair number of helicopter EMS crashes in the 1990s, and it was fairly well publicized, and that really changed how many programs operated. So there's, I guess, maybe two parts to this question. I'm sure we'll forget one of them, but the first one would be, how much focus is there on aviation safety in both of these programs, and can you compare and contrast maybe all three, given your experience in Iceland, and then we can maybe get to part two, which I think I've actually already forgotten. But no, part two would be, with regard to that training and to that QA, in the Norwegian system, or actually, the part two of the question is there that competition amongst helicopter EMS programs, or are these mostly state-based, and run out of hospitals, or are they run by the government? I'm just curious, what the kind of makeup of the origin of these programs is as well. So I guess one would be the kind of aviation piece, and two would be what's the origin of these programs, and are there private helicopter EMS, or is it all kind of state-run, hospital-run?
So I'm going to answer this in the other order, because I think one will answer the other. The systems in all of these places, none of them are privately operated on a competitive basis. In both Iceland and in Norway, these are state-run systems. In the UK, it's funded by charity, and a lot of things are funded by charity in the UK. And I say I haven't really found out why they go that way. I think part of it is because that will afford them some flexibility from the rigid requirements of the state-operated things. So some of these things, for example, they're just a requirement to be able to show certain data with respect to outcome would have made it very difficult to get a HEMS service launched in the UK if it wasn't for the assistance of charities. So the charities were, they saw a certain benefit in this before people were able to produce the data to show that they actually made a difference with respect to quality life years. And I think that's how that came about. They managed in Norway to get these helicopters off the ground, I think probably just because they have a very different landscape. I mean, it's very rural, it's very mountainous, and just getting from point A to point B can either entail a long, windy road or just a fairly short hop in a helicopter. And so I think that sort of made helicopter emergency medical services in Norway, it gave it a fairly easy way in. In Iceland, we do not have a helicopter emergency medical service. That is something I'm still waiting on. I'm really hoping that, and it has received very positive discussion and both outside and within the government here in Iceland. But it's still something that we haven't reached that point yet. But we do have a Coast Guard search and rescue helicopter, which does provide some emergency medical services function, as well as retrieval, as well as Coast Guard functions, as well as policing duties, etc. So that is a state-run helicopter with, as I say, multi-purposes. It has various duties, which does definitely complicate the both training and various sort of and the way we run the system, let's put it that way. With respect to the second question, or the first question then, which is in regards to aviation safety, I think all three systems, whether it be in the UK, in Norway, or in Iceland, have a huge focus on safety. And they're very aware of the dangers of sort of racing to scene. So I say there's extreme focus on the level of training, on the crew composition, on the types of aircraft being used, etc. I've actually been quite impressed, and I have seldom, if ever, felt unsafe in flying with any of the 3 or 4 different services that I have flown with.
And in any of those systems, do any of the medical staff train in the aviation piece? That's not very common here either. I think many people develop a real interest in aviation, as I did. I really enjoyed, learning about VFR and IFR for all of us aviation nerds, and some of the other things, that these pilots, do on a daily basis. Is there any of that? Do any of those systems integrate the medical staff into the aviation piece, or is it, very much separate?
No, so there is some integration. So the biggest integrated part is in Norway, where they have a 3-person crew composition, where the paramedic / HEMS crew member is actually trained both as a pilot. They're not trained as helicopter pilots, but they do get trained within the system to be able to fly the helicopter, to be able to land it in an emergency situation. So they have a certain amount of aviation training. They do navigation, and they actually get trained not just in emergency procedures. I mean, they do. They go to simulators just like the pilots do as well. So they have a fairly advanced level of training within aviation as well. But they have probably one of the coolest jobs in the world, because these guys are usually either paramedics or nurse anesthetists with vast pre-hospital experience and really well trained medically. On top of that, they get to fly helicopters, and they learn to do that. And they don't have a pilot's license as such, but they can actually, do quite a bit flying wise, and get a lot of aviation training and aviation theory. And then on top of that, they do all sorts of rescue training, from tightrope slinging from a helicopter, and rescue from various types of situations. So looking at their training, it's absolutely amazing. So they definitely do have that crossover. In the UK, I think they've mostly transitioned over to, most places are running a system where, I'll start that again. So in the UK, I think there's quite a mix. I mean, some of the places are running with 2 pilots. London does, just because they're a very busy airspace, and Surrey Sussex does because they're flying at night. But some places where they're still running with 3 people, the paramedic also gets trained as a HEMS crew member with much more limited aviation training than in Norway, but they do some aviation procedures. And when I was starting my training in the UK, the doctors actually got that training as well. So we used to switch. Sometimes the paramedic would sit up front, but sometimes the doctor would sit up front. So I got a certain insight into that. I did get a bit of aviation training, especially with respect to navigation, weather, and such aspects. So we would actually take on that role as well, which was, quite fun and interesting for somebody who wasn't really ever going to go down that route, though. And so I'm very happy that other people take that over on a more professional level. But it was definitely fun to have tried that.
Oh, absolutely. I think that, we weren't specifically training in aviation, but, just after, over time, you learned to fly, you learned a lot of, of the aviation components, and it became one of the most enjoyable parts of the job, for sure. I really enjoyed that piece. And we also later on developed a fixed wing program, which became quite fun to learn to fly that aircraft as well. The next piece is actually more of a comment, and you can tell me what your thoughts are on this. But I want to then get into the Icelandic system. One of the things I think that aviation really brought, to me, or really, I kind of focused on, and in fact, one of my other guests was Dr. Sush Prusti here in Boston, who does a lot of work on this. He's a pilot and an EM doc. Was on the use of checklists and the importance of checklists, in aviation. And I remember, we'd go through this checklist and you would practice these things, and really has a lot of application. I know the OR is really good at using checklists. I think emergency medicine is just starting to integrate. I'd say EMS really doesn't use them at all unless, you're very, your program, engages in that. But, we have an airway checklist. We have, especially with COVID airway checklists. And I think a lot of that kind of stemmed from aviation, in the importance of these checklists, especially, 3 a.m, you need to go do an intubation on a COVID patient. Having that checklist in front of you, just regardless of how many years you've been doing this, is helpful. And I think that crew resource management and that checklist system really kind of, came from aviation and then infiltrated into medicine. Did you find that kind of similar experience?
So when working in the UK, we definitely did use checklists, and they still do. Before critical procedures, for example, emergency anesthetics. I think checklists definitely have a certain merit in that system. However, there has been some work done to show that if you have a very experienced provider, so this has been done within the Scandinavian HEMS system within Sweden. They have been able to show that with a very experienced provider level, the benefit of the checklist becomes less, and it does take a certain amount of time. So in a system where you have set the system very well up and you have a very experienced provider, you may actually just be wasting away a minute and a half by going through your checklist. I, however, like them. I mean, I almost swear by them. And one of the things that I liked when in that system was when I went through the checklist. You get down on your knees. You're by the trolley, by the gurney, and by the head of the patient, and you're basically ready to put the patient to sleep. But you're in a less than controlled setting, right? I mean, you're outside, maybe raining and maybe windy. You have a lot of people standing around, and things seem like they're not as controlled as you would ideally like to have them. When you then go through that checklist, it feels almost like a mantra. It feels a little bit like meditation. You go through the checklist, you hear your paramedic say check to each of those points, and as soon as you reach the final point, you realize that you've got all your bases covered. You're not gonna, you're very unlikely to run into any problems that you don't foresee. And just that puts you at ease, and your mental state definitely does impact on how you perform in situations like this. So I think just to have that system in place to sort of calm you down and prepare you for, a critical procedure, I think it definitely does have merits.
Have you copyrighted that? Because I think I'm going to borrow that checklist meditation.
Absolutely do. Please do.
Yes. I agree. Yeah, I agree. I think it really does. It's that, it allows you that kind of focus that no matter how many intubations you've done, and I think you and many of us who've done a lot of airways, can do them in our sleep. But it's that one time where you encounter difficulty or you're missing a critical piece of equipment where you realize how important, having those systems in place is.
Steve, I think you got this the wrong way around, though.
Yeah.
It's the patients that's supposed to be asleep.
Right. Yeah. I guess I have been doing it wrong. Yeah. So. I always wondered why my partners were looking at me so oddly when I'd wake up after the call.
Wake up after you're outside.
Yes. So I think, a lot of people probably have an interest in hearing about what you do in Iceland. I mean, Iceland, I've only been once, but it was a wonderful experience. It's such a unique place. I mean, everything from volcanoes to huge, amazing waterfalls to geysers that you could just walk up to, and then of course the Blue Lagoon and the many wonderful hot springs. Probably my favorite thing there. I guess the occasional polar bear I've even heard, and then of course the hot dogs. Who could resist? But I think our listeners are interested in hearing. We've heard about some of these, other well-established programs. What are you doing in Iceland, and where do you hope to take the Icelandic program?
So, first of all, let me ask you, how much is the Icelandic Tourist Board paying you for this?
Yeah, to get me into a hot bath does not take much. So yeah, they're not paying me anything, I promise. But if they're listening and interested, I could go on and on.
Yeah. So I think Iceland is a cool place in many ways. I mean, we have a country that's quite different from many other places in that we have limited vegetation if you look at the country as a whole. And Iceland is actually, central Iceland is one of the biggest deserts in Europe. It's the second biggest desert in Europe, which is something that you wouldn't think about when you think about Iceland. But deserts don't necessarily have to be hot. They just need to be uninhabitable, and most of Iceland is uninhabitable.
Right.
So the system in Iceland, if we look at the current system for advanced pre-hospital care, we have a fixed-wing air ambulance up north in Iceland, and that is a system that takes care of sort of most of our rurally based critically ill patients. They go and retrieve them, and they do about 900 transfers a year, which comes down to about 3 a day. on average, not all of them are critical transfers. I mean, they're doing anything from just repatriations, then up to sort of very, very critical patients that they transfer. They don't always take their doctor along, but they have the possibility of doing that. So they take the doctor along on sort of somewhere between 1/3 and 1/2 of their calls. And those are the more critical retrievals that they do. Then we have the rotor wing in Reykjavik, so down south. And as I say, it's a Coast Guard run unit. We're flying in fairly large helicopters, the H225 from Airbus, which is, for those who know the Super Puma, this is one of those type helicopters, and that's fairly big. So we do winching down from the helicopter, both the rescue men who are also EMTs and Coast Guard navigators. They are sort of the primary operator, and then they have us for medical support. So we do winch down. We do winch down into various different sort of types of situations and terrain. But we're doing all types of jobs. Sometimes the doctor is on board, and both on board and board. Let's just put it that way, because sometimes there's nothing to do medically, and you're just flying. You can be bored if there's little to see, but sometimes the nature can be absolutely spectacular. So, I mean, for those who want to sort of get a very good view from their office, well, this is definitely a job to recommend. As I say, we have a very varied type case mix. We do some HEMS type work. We're doing retrievals of both ill people from the sort of area in and around 50 to 150 kilometers distance from Reykjavik. But then we're also doing some retrieval work, for example, to the Westman Islands. That's just south of Iceland, because otherwise they have great difficulty getting their patients over to the mainland, and the hospital there is quite limited. But most of what we are sort of tasked to do and trained to do is rescue. And rescue can involve obviously just somebody who's uninjured and just needs to get winched onto a helicopter to get them to a situation of safety. But quite often, rescue can entail either an ill or more often quite injured patient that you need to both be able to treat and stabilize at scene, and then rescue them and bring them to hospital. And I think that's one of the things that I wanted to talk about as well, Steve, is just contrasting the difference between jobs in in the HEMS type system, a blended HEMS rescue system, or a primarily search and rescue type system. How we approach jobs, what our training allows us to do, and also what limitations those situations can impose.
No, it's interesting. It's really much. It sounds there's much less of a focus on strictly the medical piece, and it's more of a kind of catch-all that you're doing some rescue, you're doing some medicine. It sounds like you even do some enforcement. Maybe even some nature photography, it sounds, possibly as well. And then, we have a Coast Guard system here in the U.S. that is really part of our military, and they do a lot of search and rescue. They do a lot of law enforcement, but they're not involved at all in the medical piece. And they do some medical transport, but when they do that, there's no medical personnel on board. It sounds like there's some similarities there, but with the addition of the medical piece. And so, we're coming up on our time. So I think, what I think would be interesting to hear is then, knowing that and hearing about that system, and you've been in so many other systems, you're bringing so much experience, to this Icelandic system. What's your if you can speak on this, what's your goal for the future for further developing that? Is the system that you have currently where you'd like it to be, or do you feel that there's room for progress and room for some change to further develop the program?
Okay, so I'm going to steal a couple of minutes just to talk about one thing before that, and then we'll go into that. Of course.
Yeah.
Okay, so one of the things that I've sort of run into in trying to transfer my experience from these more rigid and well operated, well trained HEM services and into my job in Iceland is that because of the hugely varied role that we're doing, we're sometimes just retrieving people from not just a mountain top, but the side of a mountain. And last winter, for example, we had 2 patients who had fallen down a mountainside in the middle of winter. They had just slid down an icy bank, and accessing those 2 patients for one thing was quite difficult. So we had on crampons and axes with us. When we had gotten down onto the mountain, I realized that they were sort of in a valley that we wouldn't be able to access, without risking losing our footing and sliding down ourselves. So we ended up having to, despite having being winched into a place where they didn't think they would be able to winch us directly into the valley, but we weren't able to get to the patients without that. So they had to sort of, the pilots had to breach their protocols a little bit and deliver us to a position of safety to be able to take care of these patients, and had to stretch their sort of piloting skills a bit just to be able to get us there. Once we were in this valley, all I could do really was hold on for dear life and hold on to my patient. Now, my patient, the one that I took care of, was lying face down on the hill of the mountain. I could speak to her, which meant that I knew that she was conscious and she was able to breathe. But that was pretty much all I had, because if I had risked turning her over, she would probably have continued sliding down the mountain. So I really couldn't provide any sort of medical treatment. I didn't think it was appropriate to provide any sort of analgesia in that type of setting where I really couldn't control anything. I wouldn't have been able to assist her if I had done anything more to her. So bringing in a skill set where you can perform roadside anesthetics and pre-hospital thoracotomies to a slanting mountainside where you really just have to hold on to make sure that you don't fall down, it can be quite frustrating, because the only thing I could do there was just hold on until we had a situation where we could take her over into the gurney that we were going to winch her up in, and then just get her into the helicopter. And from there, it was about a 3-minute flight into the hospital. So when I got there, it was actually quite sort of professionally unsatisfying, because I didn't get in an IV. My hands were too cold and she was too cold. I didn't know her name because the helicopter was too noisy, and I wasn't able to write anything down. I knew nothing about her except that she had fallen down a hill and I had picked her up in a helicopter. And so, being a doctor in that situation and trying to give a medical handover, I just had to say, well, sorry, I just don't have anything on this patient, but she's alive.
Oh, wow. Yeah. I'm sure they were impressed that you didn't even know her name, but all kidding aside. Yeah, that's incredibly frustrating. And having seen the landscape in Iceland, I know, that's probably one of the biggest challenges to helicopter EMS is just the different landscapes. And even though, you had a 3-minute ride, it was, probably, the scene time and the struggles that you probably dealt with, and the internal kind of thinking about, wow, this is what I could be doing in another situation must have been a frustrating piece. Those are always the memorable cases, right, that we carry with us for.
Yeah, definitely.
Yeah. And I'm sure what the nurses remember, though, is like, he didn't even ask her name. He didn't put a name. Like, who is this?
Exactly.
Yeah.
But on the question of sort of systems going forward, I mean, one of the things is, I mean, we have this blended system, and I think there are several things that I want to change in our system. Number one, we're doing our search and rescue helicopter is responding with teams that are responding from home. We're not based on site, which means that for every job that we go to, we tack on an extra half hour, 35 minutes to drive in to the base and get ourselves ready and get ourselves into the air. And for anybody who's worked in HEMS, where we realize that taking off within the next within 5 minutes of getting the alarm is usually our goal. 35 minutes really isn't an option. So that's one thing. I think we really just need to move to a place where we're spending at least part of the 24 hours, ideally the whole 24 hours on base, able to respond with a much shorter lead time. So that's one thing. I think something that will come automatically after that will also be a certain increased level of co-training. So today we do a lot of search and rescue training, but I don't feel that we're doing enough medical training. And I think we take in doctors with a certain level, expecting them to be able to perform in the pre-hospital setting because they have the training from in-hospital. But we know that the situation pre-hospitally is quite different. And it is a big ask to tell them and ask them to take their in-hospital skills and just transfer them to pre-hospital setting, but we just don't have the time and people to do the training, and especially, as I say, the co-training that needs to happen between our EMTs and our doctors. We should ideally be spending more time, and we would be doing that if we were spending more time together. The third thing that I think needs to change is the crew composition. We're flying with a bunch of really good guys. The Coast Guard navigators and EMTs are really good, and they're very professional. But I think if you look at the high functioning HEMS teams, whether they're based in Norway, the US or UK, some of the best of these teams will be a combination of a very experienced in-hospital provider, whether it be a flight nurse or a physician, anesthesiologist or emergency physician, as we're using in Europe, with a very experienced and competent pre-hospital provider, a paramedic with loads of street experience, and sort of what I tend to say, they tend to be experts in the logistics. So you come to a job that's very difficult, and they know the logistics. They know how to get a patient from point A to B. I know how to facilitate that with drugs. So those are points that I'd like. I'd like to see a more medically competent colleague, or to have my colleagues get more medical training, so that we can function better as a medical team rather than me being the only medical personnel on board. And the fourth thing and final thing is I don't think we need to be running with large rescue helicopters for all jobs. I think they are required for some and probably many jobs in Iceland, just because the weather is difficult, it demands it. We have situations of icing, extreme wind, snow, and difficult light conditions. So a lot of this will demand a rescue type helicopter with de-icing and everything. But a lot of the jobs, especially over the summertime that we do, would definitely just benefit from using a smaller helicopter and a helicopter that therefore would be easier to start up and shut down. So one of the things that we're running these huge rescue helicopters, they don't like to shut down these helicopters on scene. They're technically more difficult. They need a lot more maintenance, and shutting them down on scene can cause problems. So sometimes we come to scene and the pilot says, well, no, we can't shut down this time. And then I have to run in and try to yell to get some sort of history about the patient before being able to evacuate him to the helicopter. And in that situation, try to assess whether he needs an RSI or not, whether I should do it in the ambulance or in the helicopter or whatever. And that is one of the benefits with flying in these big helicopters, that yes, we can do in helicopter RSIs and have done several times. So that's one of the benefits. And as I say, there's always going to be pros and cons in every system, but being able to do in helicopter RSIs is definitely a pro in our system.
Oh, no, sure. And actually, we ran smaller airframes. We had the BK-117, which is, it's kind of the workhorse of helicopter EMS. I think we started
the prehistoric 135, isn't it?
Yeah, exactly. I think it started with like a pull chain, like you'd start a lawnmower, I think, and it would just like it had the kind of feel of being in a Volkswagen Bug driving down a bumpy highway. Yeah. We also had the Dauphine 365, which is a French aircraft, and now here in Boston they operate the Sikorskis, which they bought, I think, the day that I left there. But we did do RSI in those smaller frames. We used that smaller frame aircraft, and we're able to develop a system. But certainly, the more space, the better. I did have an opportunity to work on the Black Hawk, or what's called the Jayhawk, which is the Coast Guard version of the Black Hawk, and it felt like you went from the Holiday Inn to the Ritz for the amount of space that you had. It's interesting to hear some of the extremes of weather that you guys are operating in. I think that we're the non-Coast Guard systems are much less likely to work in those systems, but I mean, you have no choice, I think, given the extremes of weather there in Iceland, to function in that environment.
Yeah, as I say, I mean, there's been a lot of discussion on this in the helicopter community in Iceland, and some people say that you can't run a HEMS service in Iceland because we can't run a non-de-iced helicopter. But I'm not an expert. I'm not a pilot, but I've spoken to some of the experts, and the guys that I trust most, they say that yes, you can run a HEMS service in Iceland. You don't need de-icing for everything. It just depends on where you're going. If you're going, right across the and you need to go from the easternmost point to the westernmost point, then you're going to run into icing. You can run into icing in summertime on a helicopter. But if you're going to be doing a more locally based helicopter retrieval, with the HEMS type helicopter, you can almost always avoid those type of situations, definitely in the summertime and throughout most of the year, actually.
Well, I think that's where we have some similarities. The climate in Boston, as you know, having spent time in Massachusetts, we can go from summer to winter in a day, or sometimes in an afternoon. Well, Dr. Magnusson, thank you for spending your time and your extensive experience today. It's really, I think, interesting. It's interesting for me. I know it's going to be interesting for our listeners to hear about the different programs, the different systems. I think we need more of this, kind of opportunity to work out of our silos and talk as an international community of helicopter EMS, and learn from each other and take what we can from the expertise of other programs and share our own expertise. So thank you again. This was very interesting to hear about. And I also think, I hadn't planned this, but I think maybe this has developed a dual role for me as both the ambassador of the Bureau of Travel for Iceland, as well as maybe a side gig, doing some EMS education. I think that'd be kind of a nice program, especially if I could focus on, hot springs and things of that nature, less so on the flying through ice storms. But again, thank you for your time. Anything else you'd like to add before we go?
Steve, I'd just like to thank you for having me. I hope this discussion between us has been important, both interesting and hopefully important for the listeners. And as I say, if anybody wants to know more about the system here in Iceland, well, you can help them find me, maybe.
Absolutely. And we'll share anything you want to share in our show notes, which will be posted online along with this podcast. So I want to thank our listeners for choosing the World Extreme Medicine podcast as your source of wilderness and extreme medicine education. We are so happy to have you as partners in learning. For more content like this, Please make sure to follow us on Instagram at World Extreme Medicine, on Twitter, which is the one program that keeps me up at night, very addictive, at XPedMed. Make sure to visit our website at worldextrememedicine.com. There is our new World Extreme Medicine Fellowship program that I think many of our listeners might be interested in, and I really encourage you to look into that. And last but not least, please make sure to join us either live or virtually for the Expedition Medicine Conference in Edinburgh, Scotland. That's taking place November 13th through the 15th. It has a lineup of fantastic speakers. Vidar, you were one of them many years ago, and hopefully we'll have you back again sometime. So thank you all, and be safe out there. And thank you for joining us at the World Extreme Medicine Podcast.